I am Dr. Anjum Faridi, and I specialize in psychiatry and child and adolescent psychiatry. I am based in St. John and attached with a number of child and adolescent psychiatry teams in the greater St. John area. I also teach at the med school. Attention Deficit Hyperactivity Disorder, or as you said, ADHD, is a neurodevelopmental disorder. The term neurodevelopmental gives us a few clues. For example, it tells us that these disorders begin in early childhood. And the second clue is that these impact the developing brain. And the third is that the disorders impact the psychosocial developmental trajectory of the individual. The disorder means that whatever the symptoms that condition has cause disorder to the functioning of the individual. So the main symptoms would be the inattention and impulsivity and hyperactivity. So there can be a combination of these three symptoms. So the diagnosis at the end of the day is a clinical diagnosis. It's not like based on questionnaires and things. What it means is that it is based on that comprehensive assessment, which includes history of present and past problems, how it kind of developed, the family history, the early childbirth and developmental history, and then the doctor will be observing the child in their in the assessment session. They will try and interact with the child as well. And based on all of this, they will develop a sort of a global understanding of the kid, based on which they will be probably able to diagnose whether your child has ADHD or not. The definition and the diagnostic criteria has kind of evolved into what we currently call it like as ADHD, which the term has been around since I think 1980s. What it tells us that it is a disorder which has, there are two main features or core features involved in the name, which is attention deficit and hyperactivity. There's one silent in that, and that is impulsivity. So attention deficit hyperactivity disorder, we have three types, in which one is just predominantly inattentive type, in which there is no hyperactivity impulsivity. Another one is hyperactive impulsive type, in which there is no attentional problems. And then there is the combined type, which is the all three core features: hyperactivity, impulsivity, as well as attention deficit. The most common one is the combined type, by the way. Like many other disorders, we don't know exactly the cause of the ADHD, but what we do know is that there is a genetic component to it. The twin studies kind of show us that among the identical twins, it is about 60 to 80% of the identical twins have ADHD, whereas the non-identical twins have about 30 to 40%. Right? Which shows us, because the identical twins share the exact genetic material, and if it is common, more common and highly prevalent among those, that means that there is some sort of a genetic component, right? We also know that ADHD is about 3 to 5% more common among first-degree relatives. There is some association, not linkage, not direct linkage of like causal linkage, but some association between maternal smoking or maternal use of alcohol during pregnancy. Birth trauma, for example, is another one. So some of those kind of environmental hazards, right, or trauma can be, needs more studying. What is the biological part of the treatment? That is the medication, and then the psychosocial, which involves various types of therapies, like anything from individual therapy, and to family therapy, individual therapy with young children. Sometimes it can be difficult to engage them in talk therapies, for example, cognitive behavioral therapies. So in those situations, we will usually suggest play or art therapies. The parenting enrichment work or the family work looks at helping parents understand ADHD better, and then react and respond in more helpful ways. You may have heard these terms like stimulants and non-stimulants, right? They're the most commonly used medications for ADHD. And there are a number of kind of names people would have heard. The two main, kind of sister compounds, one is methylphenidate and the other is dexamphetamine. One of the biggest difference between these two classes is that the psychostimulants, they don't last all the time. So you give them, give the child, the medication in the morning. By the way, they work very, very, very fast. So within 40 minutes, they are supposed to be up and running. So if a kid took it in the morning before they go to school, by the time they start their, first class, it's up and running. And if it is on target, it is seen by the teachers and everybody else that there is a kind of striking difference. But then after anywhere between 4 to 12 hours, the stimulant medication will start leaving the system, and then there will be nothing left till the next morning. Whereas the non-stimulants, they are the ones that you basically take every day if you want them to work, because they have to maintain a certain level in the blood for them to be effective. And once that happens, then all you do is just replenish every day, take the medication every day, and it maintains the system and it works 24 hours. So that's a big difference between these two. A general, consensus among the child and adolescent psychiatrists and psychologists and people who specialize in the child and adolescent side of mental health issues is that it can be a lifelong problem. It is not always a lifelong problem, because many people do develop tools, and many have over decades have struggled but found ways to manage it, and many have been very successful in their lives despite of having ADHD, and they will tell you they still have ADHD. It's just that they have found ways to manage it. There's some evidence that we have from the imaging studies, for example. So they saw that the pattern of brain maturation of these children, whether on ADHD or not, is the same. But there is a delay. There is a delay of anywhere between 1 to 4 years in young people who have ADHD. So you can imagine that that delay in the brain maturation will have some impact on the psychosocial trajectory of that individual, which can go well into their adulthood. Because I primarily practice in child and adolescent kind of area, see patients up until about 19 years of age. So I tell them that, don't stop this medication at least till 25 years of age, because that's when your brain will be relatively kind of matured, and then you can then reevaluate whether you still require the medication. So first thing I will say is that don't hesitate to get the assessment, because what happens is many people will hesitate because they will think that the doctor will diagnose with some, their kid with a condition, and then they will put them on medication, right? So the way I tell the parents is that, look, we're going to do this assessment. I'm not going in this assessment with any preconceived notions, right? I haven't made up my mind, even if the teacher is saying or the pediatrician is telling me that this kid might have ADHD. I'm going in with a clean slate with you, right? And I invite you to do the same. Let's go together on this journey and explore and find out what we find. And based on that, I can give you my recommendations, right? But at the end of the day, you're the parent. And you can accept those recommendations or you can reject them, right? But let's do it in a scientific, educational way, in a collaborative way, and see whether we can, rule out or rule in if there is a problem. The first thing we need to understand or just determine whether what you're presenting or what you're bringing to me is normal or abnormal, right? If it is abnormal in some ways, based on the effect on the functioning and all that, then we have to determine whether that thing which is sounding like somewhat abnormal, whether that really is ADHD or is it something else. And sometimes, listening to the teachers, listening to other professionals, maybe your doctor already has mentioned it, it is worthwhile, going for the assessment. And I also use an analogy very commonly that, I have these correctional glasses, right? Imagine if I don't have them, it will be very hard for me to do my work. I will be stressed at the end of the day. So if you don't treat the ADHD, it's as if you're living without your glasses. And the treatment, all it is to get the glasses, the right number, the right glasses, and off you go.